and she's going to talk to us about pelvic floor rehab and just about issues with urinary leakage that occur after prostate cancer treatment and how to control those. So take it away, Kelsey.
Yeah, like she said, my name is Kelsey Davidson. I'm a pelvic floor physical therapist with Advanced PT here in Little Rock. And so today, my goal is to just make you guys a little bit more aware of what it is that we do and how physical therapy can help with specifically anyone who's going through prostate cancer and after prostate removal. So the few things that we're going to talk about today is what does the male pelvic floor anatomy look like, and how does that feed into your muscles and your symptoms after the prostate is removed. And then we'll go over the prostatectomy itself, and then what kind of symptoms you could be expecting after that process. And then we'll get into the meat of why we're here, what is pelvic floor physical therapy and what it is that we do when you come to see us. So, like I said, the first thing we want to look at is the anatomy. So the picture that you're looking at now is a side view of the male pelvis. So if you can picture a male standing in front of you and you're looking into his pelvis from this direction. So the front of the body is here. Here's the abdominal wall. The tailbone is back here. And then you can see the bladder here. And then specific to what we're talking about here, the prostate right underneath the bladder there. And then you have the colon and the rectum towards the back side of the body. And what is specifically important to us is this band of tissue starting at the tailbone and running down and towards the front to connect to your pubic bone in the front. And that band of tissue is your pelvic floor muscles. So we'll talk a lot more about what it is that they do, but this is just giving you an idea of where they're located in the body. This is another type of picture, and I really love this picture because I think it gives you an idea of how important the prostate can be in bladder function. So in this picture, your bladder is here at the top, and then this large structure here is the prostate. This tube coming from the bladder and emptying it down this way is the tube that empties the urine from the bladder out of the penis. And so you can see how it's completely encircled by the prostate. When you still have your prostate, that structure there applies pressure that helps you stay continent, meaning it keeps the urine in whenever you want it to stay in and allows it to pass whenever you're trying to empty, right? And then again, like we talked about before, right below that prostate, kind of hard to see in this picture, but right here is the section of your pelvic floor muscles. So imagine after your prostate is removed, these pelvic floor muscles are really one of the only structures that you have left that is there to support your bladder and keep you continent after that prostate has been removed. So what are the pelvic floor muscle functions? You can think about it as the 3 S's of the pelvic floor. So the pelvic floor is supportive, it is sphincteric, meaning it controls what comes out and when. And they are also very involved in sexual function. So we'll go through and talk about each of these individually. So when I say that the pelvic floor muscle group is supportive, you can think about it as being a component of your deep core. So we always think about your core muscles as, your 6-pack abs or the ones that everyone sees at the beach, all that kind of stuff. But you have a deeper set of muscles that your pelvic floor is a part of, and those muscles are hugely important in bowel and bladder function. So in that picture before, you saw the abdominal wall in the front, and your pelvic floor, when it functions correctly, is always talking to those deep core muscles in your abs and helping you to stay upright, to walk through space, to exercise. If your abdominal wall muscles or your pelvic floor muscles have gone through some type of injury, which is really typical after the prostate is removed, then that crosstalk between the two is lacking. And that can lead to pain with exercise, that can lead to specifically bowel and bladder issues, which are really common after prostate removal. Your pelvic floor also really helps support your low back. So again, the muscles in your low back, in your abdomen, and in your pelvic floor are always talking to each other, trying to figure out how they can best support you as you do the things that you really want to do. So after prostatectomy, some men will complain of pain or instability or leakage during a golf swing or during a tennis swing or when they're getting on and off their motorcycle. Things like that that you want to get back to doing in your everyday life really take some rehab, and we have to address pelvic floor and the muscles in the front and the back to make sure that they're talking to each other when they're supposed to be. And then the last thing that your pelvic floor supports is what you just saw in that picture. So all of your organs that rest right on top of your pelvic floor. So your prostate is there, your bladder is there, and your rectum is there. And so your pelvic floor can act as a little hammock or a little sling of support. And that's even more crucial when the prostate is removed, because that is a big structure there that just the size of it contributes to the support. And so once it's removed, your pelvic floor really needs to be strong and coordinated and healthy to give that added support. Pelvic floor muscles are also sphincteric. So you have pelvic floor muscles that, like we talked about, surround that tube that empties the bladder. Then you also have pelvic floor muscles that surround the opening of the bowel or the anal opening. And so these muscles are completely voluntary. That's the great thing. You have complete control over when you squeeze these muscles and when you relax these muscles. So of course, we understand that sometimes we want things to leave, right? Whenever we're trying to empty our bowel or our bladder, we need our pelvic floor to relax. But then when we're exercising or when we're talking, lifting our grandchildren, something like that, we need them to be able to contract so that we don't have that leakage or we don't have the other symptoms. So that's why it's good that they're voluntary, you can control, and that's why physical therapy helps, because we help to strengthen those muscles. Like I said, they play a major role in maintaining continence and or reestablishing continence post-prostatectomy. And research does tell us that strengthening these muscles results in decreased urinary and or fecal incontinence and a shorter recovery time post-surgery. So we'll get into that a little bit later, but if you can work on strengthening these muscles after your surgery, as opposed to just kind of letting time be the healer, then all of your symptoms will be lessened in a shorter amount of time. So again, this is that picture just showing you where these muscles are in relation to the bladder, and how if you squeeze those muscles and contract them in the right way, it can give you enough pressure around this tube that empties the urine to close that off and help you to control the leakage. And this next picture, like we talked about, some men can have bowel issues after prostatectomy. So that can mean that you're losing gas or stool whenever you don't mean to, or it could be the opposite. Some men complain of constipation and not being able to fully empty their bowels. So all of that has to do with how your pelvic floor is functioning. So you can see in this picture, here would be the base of the penis, and then here would be the anal opening. And the pelvic floor muscles form really a perfect circle around that opening. So if those muscles are weak, or they're too tight, and they're not coordinated, it can make things coming out or emptying your bowel really difficult. And that third S of your pelvic floor, they play a huge role in your sexual function. So we know that sexual function or decreased function in that area for men post-prostatectomy is a really big concern for the male and for their partner. And so the idea is that if we can strengthen and wake up these pelvic floor muscles, that you can get increased responsiveness during arousal. These muscles perform a rhythmic contraction or repeated contraction during orgasm. So we know that if these muscles are stronger, that rhythmic contraction is stronger, and it can produce orgasm. We know that pelvic floor muscle exercise and biofeedback are an effective treatment for men with erectile dysfunction. So like I said, all of those three S's that your pelvic floor functions as are very important in decreasing your symptoms after post-prostatectomy. So this is that same view here. And for here, I want you to look at this triangle of muscles here. So these are muscles that you can actually see and touch from the outside. In this picture, the skin has been removed so you can look directly at the muscles. But this little triangle of muscles here are the ones that are specifically responsible for that increased arousal, rhythmic contraction during intercourse. These muscles are also voluntary on the outside, so that's why you can strengthen them and hopefully get some of that sexual function back after prostate removal. So what are people typically experiencing after prostate surgery? I'm not sure where everyone is in the process. Some of you may have already gone through the surgery, some of you may be awaiting that process. So this may be some things that you're currently experiencing or things that you have questions about your experience after the surgery. So these first three listed here, the ones with the little asterisks, are ones that we see a lot when men come to see us for physical therapy. So urinary or fecal incontinence, and that means the loss of urine, stool, or gas whenever you're not meaning to. So this is very common but never normal, and any amount of loss of urine or stool is considered incontinence. So even if you're just having a little bit every now and then, that's something that we can still help you with. Urinary urgency and frequency. That means that whenever you feel the urge to empty your bladder, it comes on very suddenly, and it's very, very, very strong, and it makes you feel like you have to hurry to the bathroom. You have to go all the time, which is what frequency is. You feel like you have to go all the time, and you feel like you might not make it before you have leakage. And a lot of men will have urgency, and they'll also have urinary leakage related to that urgency. So like I said, they have that urge, and they're just not capable of making it to the bathroom before some of that urine leaks out. Nocturia is just a fancy word for having to get up a lot at night to go to the bathroom. And this is another thing kind of related to that urgency frequency. Depending on your age, 0 to 1 time a night is normal. If you're having to get up 2 or more times at night, that's interrupting your sleep, interrupting your overall health. And that's something that we can also help. Your muscles play a big role in delaying the urge when you get that urge. So let's say you're laying in bed at night, this is the 3rd time you've been woken up. Your physical therapist can teach you how to diminish that urge to where you can either delay it for a few minutes, or it'll completely dissipate and you can go back to sleep or go back to your golf game or whatever it is. So those are the main 3 that we often see. But obviously there's a number of other things that men can experience. So impotence or decreased sexual function, constipation, like we talked about earlier. Anytime those muscles go through trauma or injury or surgery, they can be dysfunctional enough to where things aren't being able to empty. Pelvic pain and pain with sitting. Of course, you just had a surgery to the pelvis. And a lot of times it can seem like the surgery is fairly easy, it's really common, but that doesn't mean that you didn't just have a major surgery. And so we know that surgery to the pelvis and to that area can contribute to pelvic pain, pain with sitting, pain with exercise, all that kind of thing. So all of that can be contributed to your pelvic floor muscles. So I'm going to focus a little bit about urinary incontinence because, like I said, it's the most common thing that men struggle with. You've got 3 normal types of incontinence. So the first type is called stress incontinence, and this is a loss of urine with an increase in intra-abdominal pressure. So the classic examples that we give is you're having leakage when you sneeze, when you cough, when you go to lift or push something at work, when you exercise, even when you just laugh. All of those things put a lot of pressure into your abdomen, and you can feel that whenever it happens. If our pelvic floor muscles and the muscles in our abdominal wall are not strong enough to equally distribute all that pressure that happens with these activities, that pressure can seem like it goes straight down onto the bladder, and you'll have leakage in that instance. So the idea is you strengthen the pelvic floor muscles to counteract that pressure that happens during those activities, and the leakage is decreased. Urge incontinence is what I was talking about earlier, a loss of urine related to an intense urge to void. So you might just be sitting on the couch watching a movie, and all of a sudden you feel like, oh my gosh, I have to go right now. Everyone get out of my way. And on the way, you have the leakage. Right. So like it says, unable to hold it or unable to delay that bladder urge. So a lot of men are scared to go on road trips because if they're going to have to be in the car for a while, they're not able to control that urge when it hits and you're in the car and there's not really anything else to do. Mixed incontinence is just a combination of both types. And just with personal experience, the men that I've treated, it's very common that you will have a combination of both of those types. So again, most common symptom post-prostatectomy is this urinary leakage, regardless of the type that you're having. Approximately 1 in 5 men will have some component of leakage after surgery. And when I read that, I assumed that it would be a lot higher, and I think that it probably is a lot higher than just 1 in 5 men. I would say almost all men have leakage after prostatectomy for some amount of time. I did find one stat that said 93% of men achieve continence or control over your bladder 1 year post-surgery, regardless of the type of treatment that you seek after surgery. And 93 seems like, oh, that's great. Most men achieve continence, but my first thought is you're having to be incontinent that whole year after you've had that surgery. And that's a really long time to be having these symptoms. It can be embarrassing. It can keep you from doing things that you really love to do. And so that's why physical therapy is so important, because the sooner that you get in after your surgery, the quicker you return to continence and the shorter amount of time you have to spend experiencing these symptoms. So what does pelvic floor physical therapy do to help you with this? So pelvic floor PT focuses on that set of pelvic floor muscles that we've been talking about and the muscles of your core that assist in keeping you continent, keeping the urine in when you want it to stay in. We address the strength, the coordination, and the endurance of your pelvic floor muscles during functional tasks. So yes, we look at how you can activate your muscles maybe while you're laying in bed, but that's not when most men have their symptoms, right? They're wanting to be out and being active, and the leakage is keeping them from doing that. So we test your muscles while you exercise, while you walk, while you sit, while you move in different positions to make sure that the muscles support you no matter what it is that you want to go back to doing. We also discuss behavioral modifications that could be contributing to your symptoms. So typically when someone is having leakage, if they love to drink coffee, or they have 3 huge things of Diet Mountain Dew a day, or they're not getting enough fluid in general, those can be things that can be irritating to your bladder. And if your bladder is irritated, it's saying, okay, I don't like how this feels, let's get it out, let's empty. And that can make your sense of urgency worse and can cause some of your leakage to be worse. So that's just an example of something that we would talk to you guys about is, what are you eating, what are you drinking, how much of it, what are some things that we can start to change right now that can make a really big difference in your symptoms before we even address the muscles. So if you were to come in for pelvic floor physical therapy, your first visit will look a little bit like this. So you would have an initial consultation one-on-one with a pelvic floor physical therapist who specializes in this and does this all day long. At Advanced, we're lucky enough to where if you're a pelvic floor physical therapist, you get to see clients who are struggling with bowel, bladder, and sexual dysfunction all day. So we see a ton of this. We'll take an in-depth medical history. So not just the symptoms that you're having post-prostatectomy, but what else do you have medically that's going on? Are you diabetic? Do you have a history of cancer? What medications are you taking? Because all of that can play into how you heal after prostatectomy. We'll give you education on anatomy, a lot like what you're getting here, and how your pelvic floor muscles are involved and how they can help with your symptom resolution. And then we also give you the explanation of our pelvic floor muscle assessment. So how it is that we know if your muscles are weak, or if your muscles are tight, or if there's dysfunction there. We talk you through that process and make sure that all of your questions are answered before we move on to the initial actual getting into the exam and the treatment process. After that initial consultation, you'll have your treatment session. So these are just a few things that we use potentially with your treatment. pelvic floor muscle strengthening with or without biofeedback. So biofeedback is something that gives you visual and auditory information to train the brain and the pelvic floor muscles. So we have set up at our clinic, it's a computer screen, and we use an internal rectal electrode or external surface leads. And this allows you to see your muscle activity in real time in a graph on the computer. So as we cue you to squeeze and relax your muscles, you'll be able to see and visualize, okay, yeah, as I squeeze, I see an increase in the graph here. And that gives your brain the added visual feedback that you don't usually get because these muscles are on the inside of your pelvis, and so it's hard to know, am I doing these Kegels right? My doctor told me to do them, but I'm still having leakage. And this is that added key benefit that you get with pelvic floor physical therapy, that visual and auditory feedback. Like I said before, we'll also look at how your abdominal muscles are functioning and how they're assisting your pelvic floor in managing that increase in pressure when you cough or when you sneeze or when you exercise. And then we talk about behavioral modifications that can affect your bowel and bladder habits, stuff that you can start doing immediately that allows you some relief. So, does it work? In this one study, 19% of men who attended pelvic floor physical therapy achieved continence after 1 month, compared to 8% of men who did not attend therapy. So this is just giving you the idea that men are more likely to achieve continence with physical therapy on board as opposed to no physical therapy. 94% of men who attended pelvic floor PT achieved continence after 6 months, compared to only 65% of men who did not attend therapy. So I feel like that's a pretty significant gap. 94% of men in this study who attended pelvic floor physical therapy achieved continence after 6 months. If you think back to that stat we mentioned earlier, about that same percentage of men achieve continence after 1 year, regardless of what treatment route you decide, but this could cut your time of having leakage in half. This study also noted that biofeedback assisted strengthening and behavioral modification pre-surgery can shorten the time it takes to regain continence post-op. So this is something that if you're in that stage where you're preparing to have a prostatectomy and you're talking with your doctor, ask your doctor and just say, hey, I heard about pelvic floor physical therapy. Would it hurt if I went in to see them a couple of visits before my surgery, just so that I can get a hang of how to use these muscles? And it puts you at such an advantage after your surgery because you've already laid that really great foundation and you just pick up right where you left off. A study also showed that pelvic floor muscle exercise and biofeedback are an effective treatment for men with erectile dysfunction. 40% of those men attained normal erectile function, and 34% attained some improvement in their symptoms. So just kind of a takeaway from this, I know there's a lot of anatomy, a lot of information, but what we want you guys to know is that pelvic floor physical therapy before and after prostate removal is a relatively risk-free and high-reward intervention that yields positive results for the vast majority of men. So regardless of where you're at in the healing process, if you had your surgery 10 years ago, or if you're about to have your surgery now, if you're still having any type of the symptoms that you're having during your surgery in that initial healing phase, we can help you to rehab these muscles, and we can make a difference regardless of where you're at in the healing process. So that's what we want you to take away from today. That is all I had. I think we're basically just opening up to questions.
How old, all this information, say someone's already had their prostate removed, and then they've had radiation, how effective is any of this to that?
Yeah, so we know that there's a little bit of a difference. I think I actually have. Yeah, so I pulled out some of just like the main symptoms that people have and compared what it's like for people with prostatectomy and radiation. So it can make it a little bit different for the tissues to heal, because prostatectomy, you have the prostate removed and then there's no further treatment to the tissues. But we know that with radiation, you have your treatment and that treatment can have effects on the tissues 2-3 years post-treatment, right? So, for example, this slide about urinary incontinence, with just prostatectomy, 1 in 4 will have leakage or use pads 6 months post-surgery. And with radiation, it said that 45% of men report irritation with urination after 6 months, and the majority of symptoms resolve after 1 year. So it's kind of hard to say exactly how long it will take, what the difference will be, but pelvic floor physical therapy can be helpful regardless of what treatment approach. So even if you just did radiation and you didn't have your prostate removed, we can still help in that area because pelvic floor muscles are right in the center of where that radiation is localized. And so you can assume or bet on a little bit of dysfunction in those muscles. So regardless of which treatment route you take, you can get help.
Is the prostate actually attached to the pelvic floor muscle, or does it just rest on it?
Go back to that picture. So you kind of have to think about anything in the pelvis. Almost everything is attached by what we call fascia, right? So there's fascia surrounding your bladder. There's fascia connecting your bladder to your abdominal wall. And if you look at how closely related these are, and Mitzi, you may have a little bit of different, or Sarah, but when you remove the prostate, you can assume that there is some connection there to the pelvic floor muscles. And so they're doing work to make sure that when they remove the prostate, that they're not also removing a little bit of pelvic floor, or making sure that those remain as intact as possible. But short answer, they are somewhat connected.
So they have to be incised.
I'm not.
So not necessarily incised, but think about it, you know how you were saying that it sits on top? It's not sat on top so much as like if you had a tennis ball and one of those little Velcro mitts and they're connected. And so to remove those tissues from one another, you can have some damage to that muscle, but it's not because the muscle is anchored to the prostate, and it's not because the muscle surrounds the prostate. It's just because they are on opposite sides of the same wall, if you want to think about your fascia as a wall. And all surgical procedures vary depending on your specific cancer and the location of your cancer. And so one of the things that we have to remember is that your urologists and your oncologists' first and foremost goal is to get that cancer out of your body and to try to keep you safe and healthy. And so with that being the case, sometimes they have to remove adjacent tissue that they would rather not have to remove. Yeah. And it just depends on you. And so some individuals, and that's why, you know, the robot-assisted radical prostatectomy has been such a big boon to individuals going through this treatment process, because it is less invasive, but there's still, it's controlled damage, but it's still damage to the nerves in that area and the blood vessels in that area. And it's a tough surgery. It's a challenging surgery. And so it's not that the muscles are attached to the prostate, it's just, you can almost think of it as like maybe collateral damage when they're trying to remove those things out of the body as safely as they can. Did that answer the question?
Pretty much, but is it in the surgery to remove the prostate? Is a scalpel used or are lasers used to separate it from the pelvic floor muscle?
So that's going to depend on the surgeon and the instruments and the techniques that they use. And that's a little bit outside of the scope of what we're able to cover, because it's going to vary from physician to physician.
They're always looking for clean margins. You know, that's the phrase that we all hear.
Yeah.
So if they find something in that adjacent tissue, they're going to keep going until they send it to pathology and they get a clear margin.
Mm-hmm.
So it really kind of depends on how invasive the cancer has become. So, yeah. They're wanting to spare all that tissue, I assure you, but sometimes they can't. So.
Yeah, I had a prostatectomy, and then a couple, 3 years later, the PSA started giving a reading, and I had to do radiation therapy. That's probably what happened. I had no incontinence problem after prostatectomy. There's no urgency or anything. It normalized after a couple of years. But after the radiation, it became more of a problem. That's probably what happened. They took a little bit of that muscle out to get the clear margin. Dr. Mooney kept talking about the margins were all good, but had a Gleason of 7 when they started, and when they took it out and did reading it at least 9. So
Oh,
they
wow.
were really looking for everything to get it out.
Yeah.
So maybe that's why I'm now having more incontinence. Later on, I'm having continence problems.
Like Kelsey was saying, radiation really does change your tissue. It makes it a lot more fibrous, it makes it a lot tougher, and so when you go through radiation, it is harder for those muscles to work like you need them to. And that's why a lot of gentlemen that go through radiation treatment need additional assistance, making sure those muscles, whatever the potential for those muscles are, have really been maximized, because they have an additional disadvantage of those muscle fibers not being able to work together as well because of the damage from radiation.
I'll also say at the top of that, just right at the level of the urethra, where the urethra attaches to the bladder, there is an internal muscle that they really try to spare as well, but often it gets sacrificed. It does, and so I've often said you go into that surgery with 3 things that are compressing, you know, your urethra, and you may come out with 1, which is the muscular wall that we're talking about. So if you have a weakness there, you're in trouble, you know, so, but they try to spare that if they can.
Some men have the continence issues and some don't. Some men have none initially and they develop later. Is it a direct correlation to the strength of the pelvic floor muscles, as in when you start doing and then you stop, and you develop issues, or you have weak muscles to begin with, so you have incontinence? You have strong muscles to begin with, so you don't?
Yeah, and I don't know if we can say that it's a direct, like, cause relationship, but we definitely know that a stronger pelvic floor prior to surgery yields better results after surgery. And that's kind of, you know, if you were to go, let's say you had a shoulder repair, and you had an extremely strong shoulder musculature prior to your repair, you're going to be at a better advantage during your rehab afterwards. It's the same idea with these set of muscles. So if that answers your question, yeah, if a stronger set of muscles prior to gives you a better advantage after the fact. Just because your brain knows how to connect to those muscles, that brain muscle connection is firing a lot more efficiently, especially if you've learned how to do that prior to, right? If you have to learn all of that and strengthen after the surgery, then that puts you at a slight disadvantage compared to someone who doesn't.
And Dwight, I'll throw on top of that, it's rather interesting, and we get together collectively, we have lunches, we talk about things, but I'm amazed at the number of gentlemen that come in and you talk to them and they'll say, well, you know, I've been doing those exercises that the doctor told me to do, and when I see them doing that, my immediate response is, well, you're gonna have buns of steel. That has nothing to do with your pelvic floor, you know, because they don't have that ability to isolate, they don't have that connection. Yeah, exactly, that's why the biofeedback is so helpful. But the other, I'm sorry.
I have not embarked upon any of these treatment protocols yet. So is there anything I can do at this point, as I progress to that point, to strengthen this pelvic floor, you know, on a day-to-day basis?
Yeah, so of course we'd like you to come to therapy. But if you think about, like Mitzi was saying, it's important that when you're exercising these muscles, and I'll explain how to do that in the right way, that you're isolating those specific pelvic floor muscles and not squeezing your legs together or really crunching your ab muscles or squeezing your glutes. So think about the cues that we give men when they come into our clinic to really isolate the pelvic floor would be something like draw the anal opening up and in. Or imagine you're trying to shorten the penis or lift the penis. That little cue, it's kind of like, takes a little bit of finesse because it's a small set of muscles, but if you can think about drawing that anal opening closed and up and in, you'll feel, like if you do it in your chair right now, you'll kind of feel the bottom of what you call your perineum, or that skin, lift up a little bit off the chair. And then if you release that contraction, you'll feel it rest back down onto the chair. And that's how you know, that's just a good way to know if you're doing it correctly at home. And just always checking in, am I squeezing my glutes? If your glutes are sore after a day of doing your Kegels, then you're probably using your glutes too much, right? Or if your abs are sore, same idea. So that cueing, we always say, I don't know if I have a slide on there, but just test yourself. So say, okay, I'm gonna try and squeeze my muscles without using any extra muscles and see how long I feel like I can hold it. So let's say you squeeze and you have a good strong squeeze for about 5 minutes or 5 seconds, and then it starts to fade. So 5 seconds is maybe what your muscles can do with the correct technique at this point. So we would say, okay, start with 10 repetitions of a 5-second squeeze, 20-second relax, and do that set of 10 reps 3 times in a day. It's easier for your muscles to do that in a laying down position because you're taking gravity out of the situation. But as you get better, you can transition to sitting or standing, or while you're walking to your car, practice squeezing those muscles. So that would be an example of what you can start doing now, making sure that you're doing it correctly, getting those muscles isolated. And then 3 sets of 10 reps at however long it is that you're able to hold at that time.
I think the maddening thing too is when you look at predictors, a lot of people say, well, is there any way to predict who's going to have problems afterwards, and maybe who potentially won't? And one of the common themes that you'll see in the literature is really the thickness of the muscles going into the surgery. So the thicker the muscles simply means the stronger they are. So again, that's all the reason you need to just think about isolating the muscles, finding them before the surgery, and then being able to strengthen before you even go through the surgery. That's so helpful. So
My surgery was 9 months ago today, so it's my 9-month anniversary.
Yeah.
yay.
It was a quick process, and that I was diagnosed in June of last year. I met with Dr. Langford about a week after diagnosis, and we talked about the procedure, and he mentioned 4 exercises then.
Right.
And I started doing them then. I then had my surgery August 15th. I didn't have any problems with continence. After the surgery, everything is going well. I stopped doing them. And then I noticed a little leakage, so I started back.
Yeah.
And
Exactly.
Gravity's not going away.
Yeah. Yeah, and just like all muscles, if you don't use it, you lose it. And so as we continue to progress through life, if we don't do things to maintain our muscle mass, and that's anywhere in the body, that's globally, then that strength will start to dissipate. And because like Mitzi had already mentioned, some of the only things now that are supporting your continence mechanism are those voluntary muscles. It's essential that you maintain that practice in a way that makes sense for your life. Like we were talking about, incorporating it into things you're already doing. Stopped at a red light, do some exercises, lifting a bag of groceries, squeeze your pelvic floor to support yourself so that it becomes second nature and you're not having to think about, oh, I need to do my exercises X number of times a day. It's just as automatic as covering your nose and mouth before you sneeze or cough.
Does being overweight have any effect on your pelvic floor muscles?
Yeah, it definitely can. We know that an increased BMI or body weight is a risk factor for urinary incontinence. And you can kind of think about that as, especially depending on where you carry your weight. So for a lot of clients, if a lot of your weight is distributed in the middle, in the abdomen, that can add added pressure that your core muscles and your pelvic floor are then having to stabilize against, if that makes sense. So yes, it is a risk factor for incontinence. And that's kind of for anyone, not just post-prostatectomy, but for anyone we see, men and women, who come in with leakage.
And respiratory disease is another really big risk factor. So if you have uncontrolled asthma, you have COPD, anything that's increasing the pressure, because your pelvis is a type of diaphragm that works with your breathing diaphragm. So it's even more strongly correlated with an increase in leakage. Respiratory disease is than obesity or overweight. So that's something to think about too.
I've actually been through your program
Great.
about 7 years ago now. And one of the things I've continued to share with everybody through the group and over the years is that, yes, the Kegel exercises are wonderful, but we're all doing them wrong.
Yeah.
Until you
Yes.
have been trained by
That's right.
physical therapy, you don't know what a Kegel exercise is. The other thing that as we're all sitting here and talking about it, we say, oh, we do our Kegel exercises, we do it at a stoplight, we do it in our chair, we do it when we're watching TV. If you do it like you teach us to do it, you have to focus on it, you have to be thinking about it, and you are wore out after a session.
That's true.
Yes.
So it is not to be taken lightly, and the word exercise is very accurate. It is a full exercise, and you will know you've been through an exercise program at the end of the session.
It takes a lot of, it's kind of strange to think about, but everyone who comes in to see us and they're having these issues, we're trying to lay that foundation of, okay, can you contract your pelvic floor in the right way? Can you contract that with your abdomen? And can you breathe at the same time? And it's amazing how much brain power and focus that can take for a lot of people. It's kind of like rubbing your belly and patting your head at the same time. It's like your brain needs that added guidance to help you lay that foundation. And that's what he was saying. It takes a lot of focus, and it really does feel like you're exercising and you've worked out afterwards. Towards the end of therapy, you got that foundation laid down, and like Sarah was saying, you keep that strengthening up, and then that will transition you to where you have to think less about it as you move through life, as you exercise, and it becomes second nature. But yeah, you're exactly right. It takes a lot of brain muscle connection and rewiring that connection at the beginning.
So how long do the therapy sessions typically last of your actual exercising? And I guess there are different intervals and.
Yeah. So typically, if you come to our clinic, I'll give you kind of an average length of treatment overall, and then what an average session is. So an average that we give everyone is we like to see you twice a week for 1 hour each session for an average of 8 to 10 weeks. So depending on where you're at in the healing process and where your muscles were prior to, it may not take you the full 8 weeks. We may get to that 5-6 week mark and you're feeling really good, not having any more symptoms, and then we discharge then. But each session is 1 hour long, one-on-one with your pelvic floor therapist. You always see the same therapist each session. And then, like I said, preferably twice a week for an average of 8 to 10 weeks, depending.
I can't find any solid information on exactly what coding is. And even as I talk to doctors, they don't say much about it.
Can you repeat that? Sorry, I didn't.
Exactly what coding is.
Yes.
And even when you look at it online, they don't say much about it.
Yeah.
Or just tell us about it.
So this is, I'll kind of speak from like patient experience, and then you guys can jump into. Oftentimes during orgasm or during ejaculation, your abdominal muscles are really firing. And a lot of people will also kind of bear down during orgasm. So they're holding their breath and they're pushing down to either enhance the sensation of the orgasm or to help get there. And so that's in combination with holding your breath, really activating your core muscles strongly and pushing down, that can really increase that intra-abdominal pressure, cause pressure onto that bladder, and it can result in leakage at the same time as orgasm. So if you kind of just think about, am I doing those things, and try and relax your abs and continue to breathe through the process, that can relieve some of that pressure and decrease the amount of leakage.
One of the things that can happen too is that part of the natural continence mechanism during orgasm, in that urethral sphincter that's closest to the bladder is shut off. If that sphincter was damaged in that prostate removal process, you can think about it almost like a faucet that can't be turned off quite all the way. And so that can happen as well. And I don't think that there's a lot of really good research on that because that hasn't been done yet. They haven't isolated, individuals that have dealt with that and looked at, well, why is this happening with some people rather than others in the literature. And so I think that's why there's a lack of information on, and sometimes too, like you disclosing that takes a lot of courage, and people don't always disclose those things to their doctors. And so people may deal with it even more than their physicians realize, but people aren't able to disclose that because they just aren't comfortable with it. And so that can also be a gap in why we don't have good understanding about the symptom that people are experiencing.
It's highly underreported. And not that it makes it okay, but just as far as information for the partner is, urine is sterile in the absence of bacterial, infection. So there's no concern for that. It's not that we want that to happen, but I'm just saying there would be no physiological concern for that for the partner.
You're welcome.
One thing I wanted to mention too about statistics about this is how you guys define continence
Yes.
as opposed to how some doctors define continence may be different.
That's very true.
So, I mean, what they're saying is continence is no leakage, period. But for many urologists, it's if you have to use only one pad a day for
Right.
continent.
That's exactly right.
They're
Yep.
real different things, and it's kind of misleading when you see some of the
That's very true.
statistics.
I agree.
Pardon me? But it's not talked about enough,
It's not, yeah, it's really not.
especially prior to surgery.
Mm-hmm.
The potential for that development to strengthen you prior to.
Mm-hmm.
Is the Kegel app still?
It is.
Kegels?
Yeah,
Kegel app.
there's a lot of different apps that you can use. We have some of ones that we like, but if you go to the App Store and you search the word Kegel, Kegel, a lot of those will pop up, and that's a way that with guidance from your physical therapist about where to start you on that home exercise program, or if, like we were talking about, if you're not quite ready for therapy and you just are working on it at home and you think, okay, I can hold on for about 5 seconds. There's these apps that you can enter in how long you're squeezing, how long you're resting, for how many reps, and it'll basically just cue you to squeeze, relax. And it's a lot easier than having to think, okay, I'm up to 20 seconds, I'm holding the timer here, I'm trying to watch the clock while I'm squeezing. It kind of does that part for you. And so I think that when you've got the app and you have something that can say, hey, you did your stuff today, that can be really reinforcing for wanting, you wanting to continue that. So apps are really great.
After 8 years dealing with this, I'm convinced a lot of it is mental. I mean, I can go for hours. I mean, hours. 4 or 5 hours. Or maybe, but whenever I approach the house,
Key in the door syndrome.
Yes.
Yeah.
I mean, it doesn't matter whether I've been out for 5 hours or 1 hour, it doesn't matter.
Right.
The brain says, uh-oh,
It does.
it's near,
Okay, you can go for hours doing what?
without any
Without
problem.
waiting.
Oh,
Leakage at all.
okay.
Yeah.
And it's a huge, and exactly how you said it, your brain
Oh,
tells
your
you
brain
that, right?
knows that you're approaching the house.
Your bladder was fine 2 seconds ago, and then you drove up into your
Or
driveway.
it might be the Walmart bathroom. I mean,
Yeah, exactly.
Everybody has different triggers.
yeah, it's
And that's
triggers.
and that's what we ask people when you come into therapy and you do the therapy process. Your therapist and you identify what are your specific triggers. Some people, like Mitzi said, we call it key in the door syndrome or
Yeah.
key in the lock syndrome. We tell people your bladder is smart. It knows what your neighbor's car looks like. It knows what the sound of your garage door is opening.
That's right.
And so for some people it's feeling cold, for some people it's hearing water running, for other people it's seeing the toilet. And so we get really creative in troubleshooting with you how to use what are called urge suppression techniques.
Right.
And so that urge suppression, the more you give in to the bladder urgency, the more likely you are next time to have another
Yes.
inappropriate bladder urge.
Right.
And so we help people work through that because it's so frustrating. It's so frustrating.
Are there any questions?
I think that I manned this correctly according to Google, and it didn't look like anybody had any questions. We got 1 thumbs up and several people watching, but no questions from our online audience viewers. Online people, would you like to ask any questions? We've got nothing, so
I will just say to you, I just put a couple of resources up here. I'm sure that you guys are familiar with a couple, but the one I wanted to hit on was this bottom one. Dr. Kelsey Wakefield is a couples therapist through the UAMS Couples Center here in Little Rock. And so we work very closely with her. She sees a multitude of different types of people with different types of issues, but we know that sexual dysfunction after prostate removal or any type of treatment for the prostate can have an influence on the relationships that you're in. And so sometimes you're in a place where you and your partner can talk about that and work through it. And sometimes, you can talk to one of us about that, your therapist, but we always encourage anyone who's having trouble in your relationship to go to someone who sees couples working through this on a daily basis, and Dr. Wakefield is amazing. And so that's just one example. We use her a lot and refer to her a lot, but I mean, you can see anyone. It's just getting that, a little bit of guidance about how to maneuver the relationship through this new stage in life can be very, very helpful. And like Sarah said, it's hard to talk about, but once you're on the other side of it, the more people that you've got in your corner and on your team, the better. So that's just something to think about if you haven't thought about that yet.
She has a personal journey to, her husband actually had prostatectomy and had erectile dysfunction, so she's very in tune with that. and
Yeah,
she's a
very
great
sensitive.
resource. She is an amazing.
Fabulous.
We may be inviting her.
Oh, yeah.
I think you should.
She's
Great.
phenomenal.
Very
I'm glad
dynamic
to know
speaker.
about her.
Yeah.
You would really appreciate her.
Just a wealth of information and on intimacy and connection, and
Absolutely.
yeah, you guys will love her. She's
It'll change the
phenomenal.
way you think about
Thank you
sexual
very
behavior,
much.
for sure.
So she's at UMS.
She is. Mhm.
She's under the.
Yeah, she was on
She
TV.
was.
Yeah,
She's
she
under
did
the
a little.
psychiatry department.
Yeah, it's with the psychiatry department. But she did a talk with Channel 7 or Channel 11, like one of the morning shows. She did a talk. So
Well, y'all can count on that. I'll be in touch with you.
Yeah.
yes, awesome. Am I good to in the feed?
I think so.
Okay. Bye, online viewers.